following is a conversation. It has the features of any conversation, such as imperfectly expressed thoughts, ill-considered opinions, and the notions of several sleep-deprived brains. Try not to get your stethoscope in a twist about it.
On today's show, my co-hosts are going to share some of their memorable patients with us. But first, as we record this, it is commencement, graduation day for officially no longer medical students. Now they all have to bitch about something else in their lives.
It's my one personality quirk, and I'm gonna have to figure out what else I'm gonna complain about.
The world on the plus side, the world is your oyster. There's probably nothing to complain about in residency.
That's what I've heard.
So smooth.
Yeah,
Internship is great.
It's all smooth. Yeah, it's the perfect perfect blend of work-life balance and all that kind of stuff.
Especially in your
fantastic.
specialty is well known for that.
Yeah, OB-GYN is one of the best when it comes to work-life balance. So, now that I can't complain about medical school, I'm going to have to complain about like politics or something dumb. I'm not looking forward to it.
Oh, there's other things to complain about.
Traffic.
Yeah.
I can complain about that.
Yep.
Where are you going? You're staying here.
I'm going to St. Louis.
They've got a gate.
Yeah, they got a big
gate.
old arch.
The arch. They've got a
I think they call it a gate.
Gateway Arch is the official.
The gateway to the west, right?
Yeah.
Something like that.
Its official name is the Gateway Arch.
Rick Riordan thought that it was closer to the river.
Yes, and Percy Jackson would have survived the fall.
That's my absolute favorite thing. Because when they made the Disney series, everybody was like, "I'm really excited to see how he handles that." And then they show it, and he posted on Twitter. In my defense, I thought it was closer.
It is like right next to the river, but I'm not sure if you can jump from the arch into
I'm
the
pretty
In his mind, it was like on the river,
Above.
like you could
Above
fall
the
off the
river.
arch into the water.
The arch is over the river.
Which is not.
I will
quite
tell you
the
what, that
case.
would make more sense, I
Yeah.
think. The arch should be over the river.
I know, like a McDonald's arch. Just
Yeah.
One.
Well, the river runs north-south, and he was trying to. It's a gateway arch to the west of the United
Well,
States.
Eero Saarinen, that's the name of the guy, the architect, I think.
That's insane that you know that. I'm really proud of you.
That's all I can say about it. Eero Saarinen.
He's got a name.
That's a really
Just
good
gonna
story, Dave.
Throw out that name and hope that nobody tried to follow up.
Meandering in the margins of medicine, it's the Shortcoat Podcast.
Weird news,
Fresh views
helpful clues, and interviews.
by students for students.
Subscribe to our weekly show at theshortcoat.com.
Welcome back to the Shortcoat Podcast. It's a show that gives you an inside look at medical school from the students drinking from that fire hose, a production of the University of Iowa Carver College of Medicine. I'm Dave Etler. With me today in the SCP studio, he's got things he'd rather be doing. It's M3, Jeff Goddard.
True.
She has had it with our bullshit. It's M3, Tracy Chen.
Yes, that's me.
She's bent but not broken. It's M2, Alex Nigg.
What up?
And he's finished with us. He's already made a text shortcut that automatically types a helpful read more on his future med students' evaluations. It's Dr. Matt Engelken.
Everyone's going to get a 4 out of 5 from me.
Nice.
4 out of 5, read more, no comments.
Nice. How do you feel?
I don't know. I get asked that question a lot. My family came in and they're like, "Are you sad that you're leaving?" And I'm like, I have no thoughts right now. My head is completely empty.
Those will come later.
I know. I'm sure when I'm going to start moving out of my condo and like it will hit me that I'm no longer a medical student, but I don't think that that'll come today.
Despite my emphasizing your potential for complaining during residency, this is an exciting time.
I'm
very happy
excited.
for you.
I think it'll be a lot of fun. I'm excited to start to learn how to do the medicine.
Proud of you, man.
Thanks, Dave.
You did good. Shortcoats, I encourage you to visit theshortcoat.com and pick up a Shortcoat podcast sticker or a pin, which is one way to support the show. Another way is to send us your thoughts or questions that we can talk about them. You can find that contact form at theshortcoat.com/tellus. With you graduating, Matt, and you guys and the rest of you guys with your experiences. You've all worked at Jesus Christ.
It's Friday.
Caffeine's hitting me. And
Did you guys hear that we have a Catholic Pope from Chicago?
Uh-huh.
Actually,
bet
it's Naperville, not
He
Chicago.
has probably...
No, he's not from Chicago. He's from south
He's
of
from
Chicago.
Southside, yeah.
Yeah, he's not from Naperville.
Bro
West
has
Reading
eaten
Hills.
more hot dogs than the last 246 popes combined. Guaranteed.
I want him to switch the body of Christ to a hot dog bun.
I'm not... Okay.
it's a good idea.
Did we help you with your transition, Dave? Sorry.
I mean, you gave me a little space to... You guys have all worked with patients at this point, and some encounters with them have probably been lingering in your mind long after the chart was closed. I wanted to hear about those sort of standout moments with your patients, people who surprised you or who challenged you or just reminded you why you chose medicine, maybe even made you question your sanity in the moment. Obviously, we're going to be careful about protecting patients' identities, but I wanted to start off by asking, when you first started your rotations, what were your expectations about meeting patients and interacting with them sort of in general? Do you remember what you were thinking about?
I was mostly trying to not get lost. I did my first clinical rotations in Des Moines and didn't know the area very well, didn't know the hospital.
Sure.
So I was mostly trying not to get lost and then not trying to look like an idiot.
Mm-hmm.
I think I failed multiple times on both of those, but
You're supposed to fail.
Yeah,
It's okay.
I was really hopeful that I would be able to have a little bit more autonomy than we got in our like ECE experiences, which felt more like you're shadowing. Right?
Yeah. Those are the early clinical experiences.
Yeah. One of them is you go with an M4, one of them is you get paired with the resident, another one you go with an attending somewhere.
But you're basically shadowing.
Yeah.
Sort of.
And it's fine. But I really just didn't want to be shadowing anymore. I wanted to get a little bit more action.
I had my first ECE, so the early clinical experience, way before we had any practice with any patients at all. So as soon as I walked in that patient room, I was like, I don't know what I'm supposed to say. And after that, the resident was just like, yeah, we can work on this a little bit. And I was just like, it's okay. I'm sure like the patients were like, who is this person coming in, not knowing whatever. But after the first just kind of like practice and just knowing how to interview, I was like, oh, this is much better. Yeah.
I'm going to be honest. I got pimped on my first ECE because he thought I was an M3 or an M4.
Yeah, you've got an older look about you.
He was like going through the cranial nerves. I'm like, bro, I didn't even know there were cranial nerves at all. I didn't know there were any of them. What controls the tongue? I don't know, bro. I just got here.
Alex, you're more recent.
Yeah.
With this as an M2.
I was really excited to start. It was a little intimidating because I started with pediatrics. And so a lot of what we learn is more geared towards adult patients. That was just different than what I had expected. But not only are you interacting with the kids, but then you're also talking with the parents and doing like this weird triangle of communication, which is like big in the peds world.
I cheated a little bit. And I tell every preclinical, like the best thing that you can do to prepare for clinicals is to have a kid. And nobody's taking me up on it yet. But
it's hard to require that. But
yeah, I mean, I'm not going to, you don't have to have it. I'm just going to look down on it if you don't. I'm kidding.
It's really hard to get a baby goat, okay?
But I also started on pediatrics. But again, I cheated. I had a kid. That's what made it easier for me. Is like, okay, I know how to interact with kids, even though I don't necessarily know how to be a student doctor. I know how to be a person that interacts with children, right? And I know how to talk to other parents about their kids. I don't understand the medicine yet, but I can do that. And so I kind of felt like, okay, in this situation, at least, even though I'm an idiot about what we're talking about, I can handle the social dynamics, which was probably the reverse for you. You seem like you're like the smartest person I've ever met. So you probably like the medicine you had down, but you're like, kids are weird. Their legs are even shorter than mine.
I like kids. I think they're so funny. I think I was more worried about the babies because I'm like, you can't talk. Like we learn how to talk to patients. And I'm like, there's literally no words that I can get from you. So that was like the scariest part for me.
They do like it when you make funny faces at them.
Yeah. Once they can see.
Yeah. Then, yeah. Get real close on those newborns.
Does anyone have a story about a patient that made you feel challenged, maybe attacked?
I have an experience that I was kind of embarrassed about. So I think I may have shared this on a different episode of the podcast, but my last clinical rotation as a part of my core year was surgery. And I was actually with the class below me because I had taken some time off for paternity leave. And I got called into the head of the clerkship, and she's like, hey, we got this report from a family member. It turns out the family member thought that I didn't know enough. And that I wasn't answering their questions very well. And the family member was a nurse who works here, so like maybe she just had different expectations of what a medical student should be. But I'd been doing this for 12 months, and I'm like, nobody's ever said I don't know enough. The medical student isn't supposed to really be expected to know anything, right? And two, when you start asking certain types of questions like prognosis or metastasis, I was on an oncology rotation. The medical student probably shouldn't be the one that's saying things out loud, so it's my job to not say it, right?
Do you think this is a case of you looking older than you?
I think it could be. Yeah. Yeah, I do have gray in my beard, and I understand that people assume that I'm further along than I am a lot of the time. But I was really embarrassed that somebody, I thought compared to my students who had just started, I was knocking this out of the park. And the family member was like, no, he's an idiot. And I'm like, wow, dang. So that my self-esteem was pretty shot after that one, not going to lie.
But I remember on my first ever rotation was internal medicine, and it's a long rotation. And then afterwards, I had 2 weeks of urology. On the first day, I was in a pretty long case, and they dismissed me for a lunch break. And so I was like, oh, cool, my evaluations just came out for internal medicine. And so I had left the surgery for lunch. I had checked the evaluations, and it's basically like 2.5 months of evaluations that all come to you at once. So like some people that you've had 2 months to be like, that was a really good time. Mm-hmm. And so I got all of them and I read through them, and it was like, they're not fun to read, Dave.
No,
evaluations I think in general aren't fun to read. But for me, the first core year evaluation that I got was like, oh, I feel like when people told me that I was doing a good job, that did not show up in my evaluations. And so the important part here is that since I was on a lunch break from urology for a surgery, I couldn't just leave and feel bad by myself. I had to go back to the surgery, scrub back in, and then sit there without any way to distract my mind from it. So I spent another hour or two just fixating,
ruminating
on it's something that I feel like I've gotten a lot better at, where there's always going to be good feedback and bad feedback, and you just kind of partition the bad feedback in an area where you can either decide to make it actionable or you can decide to forget about it. But this was before that transition, so I just thought about the words circling in my head with nothing to distract me, and that was a miserable experience.
I will say that I felt often that with that one terrible exception, I felt that the feedback that I've gotten from patients and their families have been a nice balm compared to the evals that I've gotten from clinicians.
Absolutely.
And not always, but either best case scenario with the clinician, I feel is they don't care, right? If they just ignore you entirely, it's okay, that I can deal with this. But usually it's going to be I don't know, 3 out of 5 keep reading. I'm like, okay, that doesn't help. Or I know it's your first day, but you should probably be better at this. And I'm like, bro, I just got here. Or he pronounces umbilicus weird. Or I don't know. But the families, for example,
is that really how you pronounce umbilicus?
I had this British/Australian person who taught me anatomy at the Carver College of Medicine, and I'm gonna keep that legacy alive.
Oh,
they're called capillaries, and this is just how I am.
You're
as a person.
Speaking of swales.
I am speaking of swales. But
there is something a little bit more cool about capillaries than capillaries.
Yeah. But those interactions that I had with patients, with parents of the little ones, or for example, in Des Moines, we had a full week that we were on newborn nursery, and interacting with new parents and helping them feel like they got this. That was so satisfying. And it didn't matter that I ended up getting an eval that said oh, you ask questions at inappropriate times. I like babies. Sorry, I asked questions. What mattered was those patients felt like somebody was there that cared about them, and they felt more empowered as parents that like, I can take care of this new life that is kind of scary and fragile and stuff. And I don't know, like, yeah, when I read that eval from my newborn nursery, I was a little bummed because I tried really hard. Turns out I tried too hard. But that feeling doesn't stay with me nearly as much as that new dad who's holding his baby for the first time. And he's like, okay, now I feel like I can do this. And I get to be a part of that, you know?
Yeah, I had a similar experience in pediatrics. And, you know, when we were talking about like stories with patients, it was the first one that I thought of. And so like I said, pediatrics was my first rotation. I started out with 2 weeks in the hospital. So that's a little intimidating. And one of the first patients I took care of was a little boy, and he had this horrible mucositis, which is like inflammation and sloughing off of some of the tissue like in your mouth.
That doesn't sound.
Yeah, and it was affecting like other areas of his body too, and it was just horrible. He was in so much pain and just miserable. And I was like coming on to that service, I was like, I've literally never heard of this. I don't know what causes it. I didn't know much about it. I got to take care of him for a few days. So I got to know both him and his parents when they were there. And I got to know a little bit more about their family and their background. And it turns out they had spent quite a bit of time at the children's hospital with a sibling. So they were familiar with this. And the mom, the entire time he was there, was so kind and calm about the entire situation. And was very communicative with her son, and I really appreciated the ownership that she gave her child over his own health care, because something that I feel is really important is trying to empower kids from a young age to have bodily autonomy and to be able to say when things happen that they don't like, or be able to like give consent to say, yes, I'm okay with this, or I want to change this. And with so many things in the hospital, you don't necessarily get a choice. It's, you have this infection, like, I don't care if this antibiotic doesn't taste good, like, you need to take it to make yourself better. And there was a conversation that we were having with me and him and his mom, and there was this like, it was this mouth rinse, and we had told him like, this might help at least with the pain. It's not going to make everything better, but we can try this for your pain and see if it helps. And he was really scared because his mouth was in so much pain that when he took the rinse, it was going to hurt. So he's sitting there in tears, just so scared of anything that might induce more pain. And we're trying to propose something that, hey, maybe this will help. And him and his mom were talking, and her along with myself, we kind of communicated to him like, hey, this is something that we're going to try. If you absolutely don't like it, we do not have to keep doing it. Like, you have the choice in what you're going to do in this situation. And it was really empowering to be able to get him to understand that and to be open. And he tried it. He didn't like it, so we stopped it. But it was just a really, really cool experience. And it reminded me of like why pediatrics is such an important time in people's lives, and the difference that you can make when you're working with kids. And I mean, you can do that with people of any age as well, but especially with kids.
Yeah, it reminds me of the idea that, you know, if you lose a patient, not lose as in death, but if you lose a patient, like lost to follow-up.
You meant just like you can't find them.
No.
They've wandered off.
Have had that happen.
That does happen.
Been there.
But like you can lose a patient to follow-up by not giving them the autonomy or not treating them as fully in control of their health care. At least that's what I've heard. And it makes sense to me. Like if you treat them as though they, you know, don't have any autonomy, then there's a risk that they don't want to see doctors anymore. And, you know, little kids are basically forming their perceptions of the world, forming their perceptions of, you know, healthcare while they see you. you might get the rinse into them, but they might sort of distrust you after that if you push it too hard.
And one of the most important things, any person in medicine has learned this lesson at some point. One of the most important aspects of the relationship is that trust, right? That you can't help somebody who doesn't see you as fundamentally on their side. And it doesn't really matter what specialty or what context, if somebody's coming into primary care, if you're so antagonistic about whatever it is, that smoking cessation or vaccinations or blood pressure, whatever it is, if they feel like you're fighting them on stuff, they don't trust you, you're not going to have a lot of success. One of the big things is they're not going to tell you a lot of things, and then you can't help anybody if you don't know what's going on, right? But on the flip side of that, I have been encouraged, surprised often by how much trust is given to us from people who, like, I haven't really earned it yet, that my field, medicine, has earned it, or at least has done its best to earn it, right? Over the course of a lifetime of interactions with this person, that they're like, I trust the people with the stethoscopes. I know that they're trying to take care of me, but when I walk in the room and I say, okay, it's just between you and me, if it's pediatrics, your parents are outside of the room, or if I'm in the emergency department or whatever, and I know that they're nervous about something, but, like, you can talk to me about it. And it's like, I'm having trouble with my genitals or something like that. And it's like, this is obviously really embarrassing for them, right?
Mm-hmm.
This is hard for them to talk about, but they feel like they can talk about it with me. And that's a really, really beautiful thing. And you're right. Like, you're just hoping in that moment, like, don't ruin this. Don't make it harder for the next person. Don't make it harder for me. Don't make it harder for them. How can we shepherd this trust in a meaningful way? And those are some of the moments that I feel like, a medical student, we're not doing that much, like, in the grand scheme of things. Like, I can't actually prescribe medicine. I can't do a lot of the procedures, but I can help build that trust and be a part of that interaction and that vulnerability that the patients are offering us. And that is probably the most beautiful part about medical school. Because you can't do all of those other things, you're not expected to do all of those other things, you get to really focus on that part.
One of the first stories that came to mind when talking about memorable patient experiences happened pretty recently. It was back in, I guess, September or August. I was on my nights rotation for OB-GYN, so I did some stuff with labor and delivery. I did a lot of stuff with, like, the gynecology side. And there was a patient that came in with this huge pelvic mass. I was the one that saw them when they came in. I had talked to them, gotten the history, all those things. And then a few days later, we went in and we did a surgery, and I was able to help out with that too, because the surgery was after hours. And pretty much immediately we knew that the prognosis was going to be bad. And so we finished the surgery. And, like you said, as a student, I didn't do a whole lot in the surgery. And the thing I do remember is that one of my roles was to check on the patients afterwards. I knew that it was going to be like comfort measures from here on out. The doctor had told the family, but the patient was just recovering, so I didn't know whether or not she kind of knew what was going on.
Tricky moment.
Yeah. And just like Jeff said, that's not the point of a medical student. Like, we're not going to go in there and say, like, you have cancer and we're not going to fix it. But I went in, I went in for a post-op check to see if pain was controlled and all those things. And it was the patient, and then a lot of the family was in the room. And I remember walking in and her being like, "Oh, I remember you. I saw you earlier this week." I was like, "Yeah, I was the first one to see you. I've been checking in. I was actually able to help out with the surgery, and here I am, making sure that you're feeling okay." And we went further, and one of the things I said is, like, I know that the doctor has talked to the family about kind of the results of the surgery, but right now I really only care about how you're feeling. Like, is your pain controlled? Are you nauseous? Do you feel, like, restless or anxious at all? Is there anything that we can do for you? And her and her entire family was just so grateful to have somebody in the moment to be there for her. And especially from the family, that's one of the things that they said afterwards is, even though the, outcome isn't what they wanted, being able to have somebody there that just like showed care for the patient was able to make a difference in that moment. And I just remember walking into the room and, you know, having them ask me about myself, and like it became a conversation. And since it was nights, you know, there wasn't something next up on the docket. So I got to spend some time talking to the family and making them feel comfortable. And I think it's one of those moments that'll stick with me forever. I know that you, Dave, and everyone else says make sure you journal so you don't forget about moments, and this is a moment that I'm not going to have to journal to remember it. But it's one that just, it shows the power of just being a person there.
I think it's an underappreciated role for medical students, at least before they start their clinicals. You're in a position to do things that doctors sometimes don't have time to do. I think that's a pretty cool thing.
I remember the surgery in particular was, you know, not a particular, like on a level for me as a student, it was not a particularly good surgery. Like I remember leaving and being like, wow, that was a bad experience,
Bummer.
like technically.
Yeah.
And I was, you know, super bummed out, and I was doing this because I was told that I had to go see the patient. But like, it was another one of those moments where I just kind of wanted to like curl up in a corner. And to go in there and say, like, see, like, a genuine happiness that I was there to check on them. And, you know, on one side you can say, like, I'm required to do a post-op check. This is, like, part of the role. Somebody was going to have to do it. But on the other side, it's, like you said, Jeff, it's one of those moments where you're like, my contributions are being not only seen, but valued. And, you know, ultimately, I think that clinicians are, and their feedback are important, but the main reason that we're here is to take care of patients, and having those moments is really a spectacular thing.
And I think in those moments, not only are you taking care of the patient and their immediate physical needs and emotional, but also the family's needs, because
Absolutely.
As the family in that situation, you've just gotten this horrible news, one that you were not necessarily expecting, and you, I can only imagine, might feel pretty helpless. And there's nothing, if someone's in pain, oftentimes there's not a ton that a family member or a friend who's there with them can necessarily do. Maybe it's that they need pain medication. Them being there in support may not necessarily, it can help just from a mental standpoint. But yeah, I think you being able to intervene and do things that the family can't can provide a sense of peace also that the patient is being taken care of, which if for a lot of people is really, really important in the hospital.
Yeah, especially when the attending doctors might only get to see a patient once per day, maybe the residents once or twice. One time in 24 hours doesn't feel like a lot. I know one of the pieces of positive feedback I got on some of my rotations is that I was able to keep the patients really up to date, because whenever there was a change, I'd be like, well, I can go say hi to them, tell them this change in person.
Yeah,
I think it'll be a good opportunity to be able to share that with medical students, right, that are training. Like, hey, you know, these are the most meaningful experiences. Like, I know you got to go do your world or whatever, you got to study, but me now as a resident, let me tell you, those were the things that made the most difference in my learning and my experience, right? And it gives you an opportunity to contribute to the team. I think, you know, you might catch a theme here. I want to be useful. I hate just sitting on the sidelines and not actually helping. But the best evaluation that I got in my clinical experience was on an IM rotation, and I think largely because I went to check on a patient in the afternoon because there was some confusing messaging going on between the PT staff and the nursing staff and the physician team, and they thought that she was in pain because of constipation or something along those lines. It turns out she was just sad. She was just having a hard time because she hadn't been spending enough time with her husband. And there was some miscommunication about what was going on. And because I was able to give that information back to the attending, they were able to not give the wrong medication. They were able to make sure that the right caregivers were part of the team and having conversations, as opposed to going down the totally wrong treatment route because of a miscommunication.
That's
right?
interesting. Yeah.
And something just seemed kind of, I was like, that doesn't seem like the patient that I had talked to this morning when I was spending some time with her. And I admit my bias. If a patient speaks Spanish, I'm probably spending an extra 5 minutes in that room easy because I speak Spanish and I just enjoy interacting with that patient population. There's a reason why patients that look like us get better care from us, right? And then everybody kind of struggles with that a little bit. But it was just kind of curious. And so I just went back and tried to have a conversation with her, and it ended up making, in the long run, it might not have been that bad of an experience to go down the other route, but it saved money, time, and energy for everybody, and it made that patient's stay a little bit better. And that's the only time I feel like I actually stood out as a medical student, just because I wanted to check on somebody because I didn't understand what was going on. Something I couldn't have done if I didn't, like you were talking about, do more than one visit in a day, right? If it's more than just that first visit at 6 a.m., you get to know what's going on in their lives a little bit better.
I feel like definitely for a lot of medical students, like their sub-internship in whatever rotation they want to do is definitely something where they can like feel that they have those like meaningful patient experiences. Especially for me, I did my sub-I last year in internal medicine, and we only have maybe like 3 or 4 patients at a time. Interns get like 7 or 8. But just I feel like it's with such a smaller number of patients, there's definitely more opportunity to go and like talk with your patients a little bit more. And definitely I just saw like, wow, these patients are, we only see the pre-round and then the whole team comes in while we're rounding. And then sometimes that's it. So I really made sure like going into the afternoons and going, hey, here's the updates on this. I want to make sure that we're kind of all on the same page. Is your family going to be here? Let's all talk together. But the one patient experience that really stood out was this patient who had been experiencing back pain for just like half a year. He went to a chiropractor, nothing really changed for him. And suddenly he finally got in to see his doctor and he was diagnosed with like stage 4 renal cell carcinoma. And within the next 2 weeks, he was admitted into here and then did all the scans, metastases everywhere. And because I feel like everything happened in such a short amount of time, it was really hard for him to accept. And he didn't really have the greatest like family support. Everything was just on such short notice. And consulting the hemonc team, my senior, the palliative team, they were all saying this prognosis is not good. But for him as a patient, everything's happening in such a short time. One day you're just like enjoying your life. You're really strong. I'm a farmer. You've kind of been independent for a long time, and suddenly everyone's just kind of telling you, hey, this is it. This is the end of life. And I talked to him as a sub-I, like, hey, this is kind of the information that I'm getting. I want to make sure that you're comfortable. And what do you want to do? Whether it's like talking about DNR status, palliative team concern. And he's like, but is there, like, can I do chemo? Can I do surgery? And I feel like med school has taught us to like have these really hard conversations, but not always the greatest at it. I started reading a Tolka one day's like Being Mortal book, and there's a line that stood out for me. It was like, they tell us like, oh, this is what you can do, the treatment. But then like, how do we handle when there's no more treatments left? There's like no more cure or anything. And then that patient, I remember it took him very long, like a lot of hard conversations. He was having rapids called, eventually cold, and he passed away, unfortunately, 2 days later. And I don't really know that if he ever really truly accepted that this was going to happen. His family, I was the one who talked to them. Actually, while there was a rapid going on, I took them to a separate room and be like, hey, I just want to tell you, this is what we're doing right now. This is what's going on. They accepted it, or seemed to accept it a lot faster than he ever did. They asked him like, hey, how long does he have? Like weeks, months? And I was like, I'm sorry to have to tell you this. I wish it was longer, because that's kind of how they train us to tell them. We can't really give you like a firm diagnosis, but we wish it was weeks or months, but we want you to prepare it. It will be like hours or days. And unfortunately, that was correct.
Wow.
In the shorter time span.
I think my, probably on the subject of things that you don't have to journal because it's just always going to be there, right? My first shift on emergency medicine, shift starts at 6 a.m. It's a hospital I've never been to before, again, in Des Moines. And so I show up early trying to figure out how to get to the emergency department, get to my desk and everything. And maybe 5:45, 5:50, I kind of wander in, and they're like, drop your bag, go in that room. They're doing a code. And so I go in there and experience the code. And time of death was like 6:05. So shift just started. Very first patient, and they're gone, right? And I'm like, wow, okay, that was fast. And the attending said, you're my med student today? Yeah. He's like, all right, go tell the family. I was like, what? He was like, all right, I'll go with you. I think he was just trying to shell shock me a little bit. It worked. And he did. It was, the father was waiting for him. This is, a middle-aged patient. So somebody that we wouldn't have expected, it's not like, they're 97 or something like that. It's not like they were fine a few days ago, right? This was a shock for the family, and they weren't expecting this. And the attending started out with, and he says, I'm so sorry your son has died. First line. And then the dad kind of like crumples a little bit. And then he kind of explains, this is what happens. This is what the information that we got from the EMT. This is what we did to try to resuscitate him. We were unable to do so. And now he's gone. And we talked about it afterwards. And I thought, wow, this is really just like ripping that Band-Aid off, right? And he said, you have to do that because they're waiting for that.
I know.
You can't spend 5 minutes explaining what's going on when all they want to know is, are they okay?
Yeah.
You have to answer that question because they're not hearing anything until that's taken care of. And I could have been taught that in a classroom, maybe at some point. I don't know, but like seeing it, and that's where it's stuck in my mind, and that's why now going into other situations when he's like, all right, now it's your turn. I'm going to go in with you, and we're going to for a different family member at a different time. Like I understand why this is important. Because I've been able to have that experience with this other family, and how well he handled it. It's crazy to think that a family member can pass away, and we're the clinicians there saying, "Hey, I'm so sorry about this," and then they thank you, like we did all we could, yeah. But it feels so weird. I'm telling you that your loved one is gone, and you're thanking me. Like it's a very weird dynamic, and again, very humbling to be a part of that, even as a medical student. Like I didn't do anything. I just stood in the corner.
On my first rotation during neurology, we had a stroke patient. Unfortunately, she was going to pass away. But I feel like I learned what not to tell a patient and their family that they're going to pass away. Is that the attending at the time was just telling, hey, this is what's happened, using really big, fancy words for like, this is what happened in stroke. This is the anatomy of the brain. And then they were just not, sitting down, meeting the level of the patient's family, and just like standing really far away from the patient, looking down at the ground and everything, and just all the while like the patient's family is like sobbing, and I have like tears in my eyes, and I was thinking, this is just like not how you should kind of have this conversation. And that's ever since then I was just like, I may have these conversations with patients, but I'm not going to do it like that.
So you learned, yeah. Some people exist to teach you how not to do things.
Yeah, it's important to learn how to do things from really great providers, and it's also important to learn how to not do things when you see things that you don't want to replicate. And one of the things that I've talked about a lot on this podcast is having the time and ability to reflect. And I know that there's days where I've left the hospital and just been like mad about either a patient interaction or like seeing a team function or whatever. And I think that there's, one side of me that just wants to forget about it and move on. And there's another side of me that says like, no, how can I not have this happen?
Yeah. How can I seize that moment and make it work for me?
There was one doctor early on that had told me that really patients can't remember more than 3 things. And so if you tell them like, a 10-point plan for what they're going to do, they're going to forget all of it. So say I'm going to tell you that you're starting a medicine, you're going to physical therapy, and I don't know, we have a consult with somebody else. It's like, number 1, this is the first thing that we're going to do right now. Number 2, this is something that we're going to want you to do moving forward. And number 3, this is another person that can help you out. And like list it very explicitly as in 1, 2, 3. Be like, the first thing you wanted to talk about was pain. The second thing you wanted to talk about was about the time frame from here to delivery. And the third thing you wanted to talk about was, what does delivery look like? And so being able to spell it out and like organize it for them, because a lot of times it's just like information. And so being able to say, like, this is the first thing you wanted to talk about, this is the second thing you wanted to talk about, this is the third thing you wanted to talk about, helps me organize, but it also says to the patient, like, oh yeah, they were listening and they were able to organize my thoughts into like nice little boxes.
Yeah.
And so I think that both from like a patient side and I've seen on a provider side, being able to kind of take either a lot of information or a lot of thoughts and being able to categorize them into more digestible pieces is really helpful, both for like my mindset and what can we solve in a 15-minute visit, but also a patient's mindset and what am I supposed to take away from this.
I think that that's probably one of the most frustrating things about medicine generally. We've got you're the most recent person that did preclinicals. About how many hours of material for a 2-week exam? We're looking at like what, 25 hours of lecture.
Yeah.
And then you got to regurgitate it on a 2-hour exam, right? We're used to like these huge information dumps and just having to retain it, right? And then I go into a patient's room and I can talk at them for 5-10 minutes and feel like I'm giving them really good information. And then I see them back in 2 weeks and realize that in one ear and out the other. And that's not their fault. Even if they get it, even if they're like, yeah, that makes sense, they've got their 3 things that they want to talk about that they're really focused on. And they've got 1,000 other things going on in their life. They've got a kid to pick up from the pool. They've got to worry about whether or not they're going to, what's going to be for dinner tonight. Do they have to fill up the gas? All of these things. And then all of my information that was helpful and that they appreciated is gone. Trying to kind of meet patients where they're at is really hard, both with the amount of information and the level of information. And it's kind of fun. I'm sure you guys have seen this too. If you follow an attending around for a whole day, they oscillate wildly, both on the amount of information and the complexity of the information that they're giving patients. And, sometimes you think, okay, so maybe he's like, the more well-to-do patients, he feels like he can be a little bit more complex, or she feels like she kind of has to make things shorter for this patient who's like trying to get out of here or whatever, right? But then I'm watching, I'm like, no, there's no really rhyme or reason. Like, it seems like it's just, they just flip a coin in their head and they walk in this room like, this is the patient that's going to get the weird, complex info dump, and then the next patient's going to get like the really short version. And I don't know, Does that
jive with what you guys have seen?
I definitely do that too.
Because that sounds very strange.
I know it does, doesn't it? But we
I've
do
seen
it.
Yeah.
Yeah.
I feel like there's some that I've seen that have like their spiels that they're gonna say, and so like sometimes every single patient gets a very similar spiel, and then other times I've seen at least a little bit of oscillation. I don't know if I've had your experience where it feels very like jarring, but I definitely know what you're talking about, where sometimes patients get like a really long explanation for what's going on, and then other times it's like, oh, you're fine.
I think so. If you guys have had a different experience, correct me, but I think my explanation that I came up with afterwards, trying to figure this out, is we're nerds, all of us. If we're in medicine, we're nerds, right? We get excited about some of this stuff, right? And I've caught myself doing that too. Like, I'm like, I talk to my wife, I'm like, I hate step 2 or I hate step 1. I hate setting it for it. And then we're sitting on the couch watching a show and I'm like, do you know the mechanism of action for that drug that they're taking? And it was like, come on, like, you don't have to be a nerd like that, but we are. So I think sometimes maybe it's like, if they're explaining, hypertension 6 times in a row, and then they've got that one patient that has, a different condition, that's like, oh, your problem is actually UTI. I'm going to go a little bit more in depth because the mechanism of action is interesting.
You've been triggered.
Yeah, the nerds clicked, right?
Yeah.
And so like, I'm gonna nerd out just a little bit, and then they go back to being normal again. I don't know if that's it. That's just a guess.
I think I also will tend to information share a lot, and oftentimes overshare to a level of detail that most people don't need to know. One, because I nerd out, but also because it like at the foundation to my being, I'm like, oh, knowledge is power. Like, I want to have my patients be informed, to understand things fully. And so I'll just sometimes like word vomit all of this stuff. Some people just don't care about it. And I have realized that in these, especially these like clinic visits where it's like, okay, 15 minutes for the entire thing, both you and the attending talking with them. And so I'm like trying to develop better ways of asking like,
Like what do you want
yes,
from me?
Yes. Like, what can I do to help you? What are your priorities? Because while I might want to know all of the information and all the nitty gritty details, that's not necessarily the same for everybody. And I shouldn't just what's it called? Like transfer all of my thoughts and what I would want and expect that out of my patients, because that's just not how it works.
The worst is when they trigger you with like that like just the right phrase, right? Like, so sometimes I'm like, okay, I'm just going to give them the rote spiel that I know I should be giving, that I've given to every single pregnant woman that's coming to this clinic all day long, right? And it's a 4:30. And then that last one says, oh, that's interesting. Oh, girl. Let me tell you what's interesting.
Open the door.
Yeah, I feel so. It's funny. My housemates, I have public health students and housemates who are also run the playwright program. So some days I also have like medical student housemates. So we're both talking about like a really cool, interesting case, and the public health students are just like aghast because we're just like talking about all this. They're like, oh my God, I never knew this happened. And the playwrights are like, keep going. We're gonna write this in our play.
This is going to end up in a play someday.
And it has.
It has.
It already has. It was
We
a
have
great
seen that happen.
play.
Yeah. I remember sitting in the play, we're like, sounds a lot like my housemate, and it was. Yeah, she wrote her housemate in.
I think being able to give information is a really interesting thing that is like sometimes taught, but is really hard to do, because like you said, every patient is different and every, clinical situation is different. There's one patient that came to mind where there's this thing in pregnancy called a non-stress test, where basically you track a baby's heart rate for 20 minutes, sometimes more, and it just shows up as a squiggly line. Kind of looks like an EKG, which is an electrocardiogram, which is like the squiggles that you see on medical things. This is not like that, but it kind of looks similar. And, the patient had gotten these non-stress tests for weeks. And I was sitting in there as the doctor was going to grab something. It'd be like a minute max. And they're like, what does this mean? And so I was like, okay, I have a minute to explain this. And that's one of the things that I saw is like, number one, as I've gotten better at knowing information, I can kind of do that transition from, information dumping to like not saying anything. But having like a time frame in my head helps me figure out like what are the things I want to talk about. But I was able to say like, oh, like if we were to wear, a smartwatch or like a heart rate tracker, most of the time our heart rate would be pretty normal, but then our heart rate would go up if we went for a walk or like went up a flight of stairs or, any of those things. And our heart rate would go up and it go back down when we stop doing that thing. And that's what it's showing here. And that's what we're looking for, is we're looking for like a normal heart rate. And then when your baby is, I don't know, doing cartwheels or punching your uterus or whatever, add in a little joke to make them feel more human. Then that heart rate goes up and it goes back down like we'd expect it to. And that's what we're looking for.
That's a good thing. We want to make sure.
Yes. And so I was able to explain like the two main things in a short amount of time. And then the doctor came back in and the patient was like, he explained what that meant. And like, and not in like in just like he was able to show me what this was, show why this was good, and to explain the thing that I've been doing and why we're doing it.
Mm-hmm.
And I was somehow able to time it perfectly. I don't think that was skill. I think it was luck. But I think that was one of the, other cool things. Number one, with being able to have a little bit more time, but also, as we get smarter and learn more information and hear other people share this information with patients, to be able to spend that little bit of time explaining things in ways that, this person has been told that their non-stress tests were normal for, once again, weeks, and they were still like, I don't know what this means.
Yeah.
So, I'm sure if I were to quiz them now, they'd probably be like, I don't know what that means. I remember you told me and I remember forgetting. But it's also one of the things when sitting in the moment, even if they forget it, they're like, that person took some time to explain something to me and it made me feel empowered for even that brief moment. And that's also a cool thing.
It reminds me of the phrase, people will remember how you make them feel, not what you said.
Those kinds of experiences are so much more gratifying and so much more lasting than any eval that I've ever gotten from a resident or an attending. You know, like when you're standing there in the room and the attending's explaining something, they're like, "Oh yeah, he told me about that, and I know that now, and I know what's going on." And I'm like, "Thank you." He just
There's no
I don't
better
care what
feeling.
he writes. That's all I wanted. I wanted you to.
There's no better feeling than being in the room and having the patient say, "Oh yeah, I remember him explaining that to me." I'm like, "Yes, I did it."
Yeah. Well, thanks for sharing your stories with me. I have a listener question that I wanted to take care of today. Let's hear from Elizabeth. She's worried about her prospects.
First of all, I wanted to say thank you so much for this podcast. I have been listening to it for a couple of years, and the advice really helped me get through the stress of pre-med, and the AITA episodes always make me laugh.
Me too.
I am currently a senior in college and will be matriculating into my top choice medical school this summer.
Nice.
My question relates a little bit to coming straight from undergrad, because it seems like most people are older than me. In our new students group chat, a lot of people have mentioned long-term partners or spouses. I have never been in a relationship longer than a year, and I'm worried that now that I'm in med school, I've missed the boat and everyone I meet there will already be in a relationship. Is this true? Neurotic? Would really appreciate your thoughts or advice. Thank you.
First, that was the AI is you're going a little far for me. It's a little much.
So,
well, I just want to say
listening to this on audio.
The one you sent us
was a gremlin.
If you're listening to this on audio, you're not seeing the fact that I discovered a new feature in my editing software this week, which is making a picture talk, and so I had to try it out for this episode. And in the group chat as we were preparing last night, I sent a slightly different. This one that we just viewed was just of a young woman, but the one I sent last night was of this demon
gremlin
woman. I just did it because I thought it was a fun way to try out this little.
I was ready to respond to a gremlin. Now I'm all caught off guard.
I'm sorry. I did feel it was a little bit insensitive to depict Elizabeth as a gremlin with sores and pustules. I thought that was just a little bit.
Elizabeth, we don't think that you
I
have
don't
sores
think you
and
have sores or
pustules.
pustules.
I don't know what Dave's on about, but
and if you do, we can go to extreme details in explaining it with information you'll forget immediately.
Yes.
We've got somebody here that's really interested in dermatology. She can tell you all about your skin.
I love infectious diseases too. So.
Oh, perfect. She had horns as well.
So my class, I mean, every class is going to be a little bit different. But my class had several people that ended up meeting their significant others in the first semester or the second semester of medical school. They started dating. Some of them have gone on to get married at this point. We're 3 years in. I've had classmates that came to medical school with another significant other, maybe a long distance relationship. Some of them are still together. Some of them have broken up and found other people. In a place where there is a medical school, if you're into things like dating apps, there's a large pool of people that you are going to feel like are your peers, people that are intellectually driven, that are ambitious. You can have farm students, you're going to have nursing students, you're going to have PhD students. The pool is vast.
Yeah.
I have seen a lot of, so far, just in my class, I'm 3 years into this, I've seen a lot of people come in single and are now very happily partnered up. And some of them aren't going to partner up until residency or later, and that's also fine. I don't want you to feel like you're going to miss the boat if you don't get it in medical school. That's also not a requirement, but it is possible to find a partner in medical school.
I remember our class, especially in the first few months, our group chat I remember there was one person who was like, "Dude, I think you matched with my sister." It's like, hell yeah, I know that.
Oh, that's funny. Yeah, this was something I was concerned about coming into med school, and I'm like, oh my gosh, I was like, I'm single, and then meeting all these people during orientation, I'm like, oh my gosh, everybody's already settled down, I'm behind, I'm not gonna have any time for a relationship now, especially because when you're starting out trying to build something, it takes more time most of the time. And so I tried out the dating apps, and I highly recommend, because you can, I met my current boyfriend through friends, but I got to meet like some really great other like grad students, and I honestly didn't want to find somebody that was in medical school. I was like, I don't want to be doing the same thing every day, but I loved the fact that like being in this position, there were a lot of other people who were like really like go-getters and were still in
similar
school
mindset
but different
as you.
program. Yeah. So I feel like being in like in an area where there are multiple professional programs, even if it's not people in your specific program, there's still a lot of prospects out there.
I am personally very wary of there's this old adage, don't poop where you eat.
Yeah.
I'm very wary of too much. The only word that's coming to mind is incestuous relationship. You get what
dating within your class or your
not
your
just
med
your
school.
class. If you're dating in a resident, and all of a sudden they're on your service, that's really inappropriate, right?
Yeah,
or if you break up, that's even worse, right?
Yeah.
I on rotations, I made a really good friend with a resident outside of medicine. Totally, I wasn't expecting to ever run into them in the clinic. And then lo and behold, on my OB-GYN rotation, they're there. Yeah. And then on my IM rotation, they're there. And I'm like, we have to keep this very professional. And we were just friends.
Yeah.
Like, I can't imagine like trying to navigate any kind of actual relationship. So if you're going to date, at least make them appear. Don't let there be a power dynamic. It gets awkward.
We have about 150 students each year that enter the College of Medicine. And I will say that that's a very small world.
Yeah.
Mm-hmm.
So yeah, I think it's probably a good idea to be wary of dating within that pool. I don't think it's impossible to do, but I mean, it could, if
you're going to do it.
I would love to say that every relationship works out, but
if you're going to do it, the best time to do it is right before clinical rotations, because then you're just kind of all spread out again. And you may or may not see them. But to your point, as far as like not having enough time, I will say my wife and I, the only reason why we're together is because we were studying because we wanted to get to medical school. And so it takes time. Well, yeah, but like in a 6-month period of time, we spent 5 hours, 6 days a week together. Every single day we were studying together. I cooked her dinner. She would wash the dishes, and then we'd get back to studying, right? So we spent so much time together, not even really trying to date at first. We were just we both had to study, right? So you can definitely log the hours, right? Even if they're in a different program. Like if you're, if you start dating a law student, they got to crank out hours too. Just sit in the same room and study together is fine.
Yeah, I mean, every relationship is a choice. I mean, you have a certain set amount of time that you have to be at school. You're going to need to put in studying hours and things, but there's a lot of it you get a choice in, like where you want to be doing that, who you want to be around outside of the required things you have to be at. So, I mean, you can curate your life to be able to fit that in if it's something that's important to you. And I'm a firm believer that if you want to make it work, you can.
Plus, it's really nice to see them in high stress situations. Like, do they like you when they're really stressed out about this test in 12 hours?
Do they like you when you're really stressed out about this?
Yeah. Honestly, because I can be kind of annoying.
I think there's a...
Yeah, my wife says I'm a tolerable asshole sometimes.
At least you're tolerable.
There's a couple things that I wanted to bring up. Number one, I agree. There's a handful of people in my class that have gotten together during medical school. And, sometimes that makes for weird situations because, as much as we don't want to be competitive with our friends, classmates, partners, it's the nature of the beast is that we can be. And so that makes it complicated. One thing that we talked about during, I think back in January, there was a show about relationship advice. And one thing that I mentioned is a challenge of medical school is that, that after 4+ years, you will be going to residency. And that's a challenge that every couple has to face in their own ways, or every, friend group or whatever relationship you want to have has to face. And that's a challenge. And some people are willing to make that commitment beforehand and do residency together. Other people choose to wait. Like, for example, my dad is a radiologist. He, I believe he was in a long-term relationship in medical school. It didn't, end up working out. But then when he went to residency, it gave him a little bit more time to have stability. And once again, a lot of young professionals there that my mom's a speech pathologist and they worked in the same hospital. And that's how they met each other. And so there's a lot of options, both if you want to find a relationship with, students, pharmacy students, PhD students, people in our classes, or if it's something that I know a lot of my friends have also really made a preference to not get into a serious relationship until those kind of next steps. So both of those are options. The other thing that I wanted to mention is, especially before starting anything, people want to show their best face in groups. People love showcasing that they're perfect. And it's really easy to say like, oh yeah, my husband and my dog and my child. And those are things that people are really proud of, and they should be really proud of those things. But, I'm guessing that you, Elizabeth, and a lot of the people that are in your shoes aren't saying like, yeah, I'm single and I'm really worried I'm going to die alone. Like, that's not exactly a good first
That's
impression.
a really good point.
And so, like, remember that if your class is 150 students like ours, there's going to be a good majority that have the same fears and worries as you. I know that that was one of the things that scared me at the beginning, is because, like, I wasn't particularly, like, looking for or interested in finding a long-term partner in medical school. And I have a partner that's going to St. Louis with me. So, like, that happens as well. But one of the things I was really worried about going into medical school was, am I like imposter syndrome, basically, long story short.
Yeah.
And people talk about their research. People talk about their volunteering. People talk about the things that they do or that they did in undergrad or in their gap years or whatever that make them feel proud of themselves or make them feel like they belong. And it means that at the beginning, I was like, look at all of these spectacular human beings. How am I going to be in the same room with them? And ultimately, I feel like a lot of them, are spectacular, but also they put on a face, especially at the beginning, to show that they are also deserving of being here. So long story short, Elizabeth, you'll be fine. If you choose to have a long-term relationship in medical school, there is a lot of different fish in a lot of different seas. And if you'd like to wait even longer, then, like you mentioned, you're young and the world is your oyster.
Yeah.
I will say that, much to your point, anybody that is talking about the fact that they're in a relationship in the group chat, that's because that's the thing about them that they like the most, right? I'm a dad. I talk about it everywhere I go. People have just assumed, based on my sense of humor, that I have children. A lot of dad jokes out there.
Sure, yeah.
But people don't walk into the group chat and talk about the things that they are not, right? Like, if you have, let's say, a group chat of 50 medical students and 10 of them are husbands or wives and parents, they're going to talk about the fact that they're husbands and wives and parents. The other 40 aren't going to talk about the fact that they're single. Like, they're just not going to bring it up. It's not going to, so there are probably plenty of people, even in these early group chats that you're experiencing, that are at the exact same social level that you are. They're just, I don't know. It's like, you don't define yourself.
It.
Yeah. That's not the thing that you're going to define yourself as. You're going to define yourself as dog mom or runner or whatever identity that you do have that is meaningful to you, not the one that you don't have yet.
And that's not saying like there's 40 people that you should date that are eligible singles in your area. That's saying that, like, in my friend group, there's been people that have been single at various times. And so, like, talking about what it's like to be in a relationship or what it's like to be single or what it's like to be on the dating apps is ways to, like, have friends. And so, yeah, when you think of all of the people that aren't in relationships, it doesn't mean that, like, you should try to be in a relationship with them. It just means that once you get more comfortable with them and more comfortable with your classmates and then your friends and, the people that you consider really close to you, it's something that you'll be able to connect with on a personal level.
2 bits of data, because I'm a nerd. I think I've expressed that emphatically. Number one is, even with dating apps, statistically, people are most likely to meet their significant other through a friend.
Yep.
That's just a fact of life. So make friends and then date their friends. Second, the number one indicator that you will have a positive feelings for another person is proximity. So, like, if you spend a lot of time with somebody, I can't tell you how often if I see 2 people in my classmates that started dating, that they were study buddies for 6 months, and it turns out it's true. And the same thing happened to me, right? Like, I just spent a ton of time studying with my wife, and turns out being right next to each other, you're like, You know what? I don't mind the way
I
that
can
she eats her
tolerate
ceiling.
you.
Yeah. Can't even say it out loud.
Careful.
Can't even say it out loud.
Careful.
My wife is perfect in every way. Also, on the subject of like comparing yourself to your partner, one of the absolute best things, because that can be a hard thing if you're dating somebody in your cohort that's doing the exact thing. It makes sense. You don't want to do this all the time, right? The trick is to marry somebody who is like demonstrably more intelligent than you are, and then you never have to compare yourself. Like my wife is leagues ahead of me, and so I never have to worry who's smarter. It's her. Like problem solved. We're just gonna move on. I have
that experience as well.
Yeah, it's so nice.
I will say somebody told me not to date the 6 Ps: physician, paramedic, police, firefighters, nurses, and lawyers.
How's that going for you?
I'm dating one of the Ps, and I am one of the Ps.
I think the other thing that is, something to think about as going through is like you said that you're going to be busy, and we're going to be busy forever. Like there's not a day that we won't be busy until we retire, and then we'll have to find out if we're one of like the doctors that has no personality and will doctor until they die, or the one that is like, I want to retire so I can go play pickleball. That's what my dad did, and he loves it.
Yeah, the happiest medical students are always the ones that make like medical school and residency and whatever, right? Like it'll take up as much time as you give it.
Mm-hmm.
If you want to spend, 16 hours a day reading medical journals, even as a physician, you can. Or you can make time for the other things in your life that make you happy, and those seem to be the medical students that are most successful.
Even if you like are the person that wants to read medical journals for 16 hours, like the point being is like it's not like in residency you'll be less busy. It's not like in the future you'll be less busy, and
so make time.
So make time, and like you were saying, Jeff, and like my experience has been is find somebody that you can cohabituate with. Like everybody else is going to be busy too. There's very few people that, well, if you're this kind of person, maybe either look for somebody like this or look for, or don't look for somebody like this. But like, there's some people that are like, I need your undivided attention at all moments. But there's also people that you cohabituate with. When I'm studying or preparing for clinic in the morning or doing any of those things, I need my partner to know, like, you can't be my focus right now because I have to be busy. And there's people that you want to be around, or there's people that you can just sit across from them at a table and feel content. And whether that be like a study group, like some study groups made me feel anxious and other study groups made me feel comfortable. And those are kind of the things that, there's sometimes where you'll go on a date or you'll have like a night with just you and your partner. And more often than that, there's the times where you have to cohabituate. There's the times where you have to be busy with another person. And so just because you're going to be busy in medical school doesn't mean that you can't be busy with another person that is also busy.
My wife likes to call it parallel play.
Yes.
Which I think is the popular term, but it still makes me feel like a toddler. I'm okay with it, but
well, look, that's our show. Thanks for sharing your stories and just hanging out with me today. It's been a lot of fun.
Thank you for having us.
Yeah.
And what kind of dope would I be if I didn't thank you, Shortcoats, for making us a part of your week? If you're new here and you like what you heard today, follow the show wherever you get your podcasts. The show is made possible by a generous donation by Carver College of Medicine student government and ongoing support from the Writing and Humanities program. Our music is still by Dr. Vox and Catmosphere. I'm Dave Etler saying don't let the bastards get you down. Talk to you in 1 week. Hi, Shortcoats. Look, life in medical education, life in America, life in the world is often difficult. And I often wish I could help. All I have is this podcast, but in my wildest dreams, you have the support you need to lead a life of your choosing. You deserve to be happy, healthy, and successful in whatever ways you define those words. So if you need support because you've experienced racism, discrimination, harassment, mental health crises, I want you to be able to get the help that you need. And so I'm going to put some links in the show notes to some resources that you can use. But the bottom line is that for what it's worth, I see you. I know you're out there. I wish I could do more. Maybe I can in ways that I don't understand yet or know about. But I see you, and I'm glad you're here, and other people are too. This Short Code podcast is a proud member of the MedEd Media Network. Inspiration, information, and guidance on your journey to medical school and beyond at mededmedia.com.